So first, to make sure that we're all speaking the same language about biochemical testing, first we want to differentiate between substance use screening with a validated screening tool. So this would be something like the 5Ps or the OPQIC screen, which is not testing a biological specimen for substance use, but just asking questions in a standardized way to look for substance use among pregnant people. So that is recommended for all pregnant people, screening with some type of validated tool. But then the other screening and testing that we talk about is biochemical or biological drug testing. And that can be done using multiple methods: urine, blood, hair, saliva, meconium, and in newborn. Obviously, urine is the most commonly used, mainly because it's the most accessible and in a non-invasive way. But these are all potential ways that people can screen or test for drugs. Now, when we talk about drug testing in general, there's screening tests and then there's confirmatory tests. And a lot of people and even clinicians may or may not realize the distinction between the two of these. But actually, screening tests generally test for a small panel of substances. Most of them will include a few common substances like amphetamines, cocaine, marijuana, PCP, and opiates. And then screening tests are generally qualitative, meaning they just say yes or no, the presence of this substance was detected or not. Now, when we talk about screening tests, we have to talk about several limitations that they have. So number one, like I mentioned, the screening panel is generally limited to just a few substances, so maybe 5 or 7. A lot of them often don't distinguish between different types of opioids. For example, buprenorphine and methadone, which are the two standards of care in terms of medications for opioid use disorder in pregnancy. Many of these screening drug tests may not actually detect those. And then in addition, urine drug screens can also have cross-reactivity with other substances. So this can lead to false positive results, which we'll talk a little bit about on the next slide. But I contrast screening drug tests with confirmatory drug tests. So a comprehensive urine drug test would involve the screening first and then followed by confirmatory tests for anything that tested positive on the screen. Confirmatory testing is not always done, and it's often not done. And so it's actually really important for clinicians when you're ordering these tests, and then also for others who are going to be interfacing with these tests, making decisions based on these tests, to know what the limitations are of the tests that are being done. So in terms of the false positives that I talked about with these biochemical drug screens, these are just some examples. On the left, you'll see specific drugs. So the first one being opioids. And then on the right, you'll see some other medications that are prescribed that can actually cause a false positive result on a urine drug screen. So for example, opioids, those can test positive from cough syrup, which is dextromethorphan, Benadryl, certain antibiotics, poppy seeds, not as commonly now because some of the thresholds of detection have changed, and verapamil, which is a heart medication. So these are all pretty commonly prescribed medications that can actually come up with a positive test for opioids. Amphetamines, similarly, there's certain antidepressants, labetalol, which is a blood pressure medication, ranitidine, which is an acid reflux medication. And you see several other examples here which illustrate that, that there can be false positives and based on really actually commonly prescribed drugs that people may or may not, take the time to actually go into a person's history to determine whether they may be taking one of these medications. Also, with biochemical drug screening, you can have false negatives. So in a test, like a screening test that has a higher threshold of detection for a substance, you can get a negative result when the substance was actually present. And so that could be just because it's been, a couple days or a few days since someone used a substance. It could be that they only use it infrequently. With chronic use, we know that that often causes the window of detection to be smaller, meaning that it's detected, even though the person hasn't used it for a longer period of time. And then again, buprenorphine and methadone, for example, generally are not detected on urine drug screens. So there's certain medications or substances that people may actually be taking that will not show up on a screen depending on what type it is. As far as the confirmatory testing, which is really the way to minimize these false positive results, the downside of that is that this requires additional lab resources in the form of a different type of test, different equipment, generally requires a trained technician to perform and interpret these tests, and it takes longer. And so these may or may not be done after an initial positive drug screening test. And then I think that, all of these aspects demonstrate that it is more complex to interpret biochemical and biologic drug testing than it may appear at first glance. And then to compound these complexities of interpretation, there's actually only limited evidence that routine biochemical drug testing actually improves outcomes. One of the strongest cases that people bring up for routine drug testing is people who are in treatment for example, opioid use disorder, who are in a treatment program where they're receiving buprenorphine or methadone for their opioid use disorder. And so oftentimes, a part of those programs is routine drug testing. But something that's really interesting that has come out of the pandemic is that because of COVID, a lot of the federal regulations involving the need for in-person visits to establish and maintain someone on buprenorphine, a lot of those regulations have actually been relaxed, and so that in-person visits are not required. So therefore, this usual practice of routine drug screening in patients that are getting these medications for opioid use disorder is not happening. And so there's some interesting literature and some interesting opinions coming out that really, by all accounts, it still seems to be going okay, even without these routine drug testing measures. So sort of a bit of a forced change related to the pandemic, but I think it may have some interesting things to teach us as we go along. And then lastly, as kind of a discussion point, I wanted to bring up a historical perspective, and some of you may have heard of this case previously, but this was actually a Supreme Court case of Ferguson versus the city of Charleston. And so this involved a partnership between a hospital and law enforcement. And this was started back in 1989. And what happened was that when women would come into the hospital to deliver, they would have a urine drug screen that was obtained without their knowledge and without their consent. And then the results were given to law enforcement, who then would actually, in some cases, come to arrest these women as they left the hospital. This case actually got taken all the way to the Supreme Court, who declared it unconstitutional and stated that in the absence of a search warrant, this violated the Fourth Amendment protection against unreasonable search and seizure. And then there's some interesting language here as well, kind of about the healthcare provider-patient relationship and sort of the ethics of obtaining drug testing without a patient's consent. And so I bring this up just to kind of give what's a pretty extreme example of some of this drug testing and policy and kind of how that can go awry. And to also illustrate the importance of obtaining consent from patients when you are doing a urine drug screen. It depends on the place, what that might look like. But our National Organization for Obstetrics and Gynecology, ACOG, does recommend at least a verbal consent. And I know that there are some, actually many places that require a written consent before drug testing can be performed. So I'd be interested to hear if anyone has experiences or thoughts at your own institutions about how this is done and, what you may or may not have seen go well or go poorly with these types of policies. So to summarize before we start our discussion, biochemical testing may be useful in some circumstances. And I think it is important to remember it's not that necessarily this should never be done, although that could be debatable in some circles, but it can be helpful, for example, if there's a medical issue of unknown cause with pregnancy. It may be something like hypertension, or cardiomyopathy that we don't know why it's happening. And sometimes drug testing can play a role in determining and distinguishing between a pregnancy-related disease like preeclampsia and the effects of substance use. This also may certainly facilitate medications for opioid use disorder like buprenorphine and methadone. And in some cases, patients actually feel that having routine drug testing is sort of a positive reinforcement, and they actually, derive benefit from that. However, it's important to keep in mind the limitations, keeping in mind that there can be false negatives and false positives. So a negative result does not rule out substance use, and a positive result doesn't necessarily mean always, what it says at face value. We should be informing patients about drug testing if we're going to be performing it, and at least getting verbal consent. And then I think it's important to remember that universal biochemical drug testing is actually not recommended in pregnancy or at the time of delivery, but screening with a validated tool is, because we certainly want to identify these people so that we can intervene and that we can get them into treatment. And then as far as neonatal screening, this is done obviously pretty widely in cases of known or suspected maternal substance use. It can be done using urine, using meconium, but these policies will really vary widely depending on the state and depending on the hospital. So again, important to familiarize yourself with the policies and the regulations based on where you're at, and to use all of this in communicating with our OB colleagues, our pediatrics colleagues, and then with our social services teams as well. And that is all I have in terms of slides. I know, I think Denise has the questions to start us off.
Dr. Pierce, this is Barbara. I have some questions that had been asked from people as they registered. Some of these have been, is biological testing considered the best way or the gold standard to capture a patient's substance use?
Yeah, I'll let Dr. Terplan start with this one because I know we were just talking about it.
Yeah, this is a great question because we assume, right, that is not an uncommon assumption, but in addition to the limitations of urine drug test results, which Dr. Pierce, you nailed, like they really, all that a drug test captures are metabolites of drugs that present in the biological compartment at a particular moment in time. And those metabolites differ. Some leave the biological system within hours, some linger for weeks or even months. So it depends on the substance that you're wondering about, but it can be incredibly inaccurate, number one. So it's riddled with, it's what the American Society of Addiction Medicine would call these, sorts of point of care tests. They would call them presumptive tests as opposed to confirmatory tests. So nothing ever that is presumptive should be considered a gold standard, first of all. Second of all, there's an emerging literature on this that looks at sort of concordance or discordance between self-report and drug test results. And generally speaking, when you do the verbal assessment correctly, comprehensively, with empathy and et cetera, like having a urine drug test doesn't change the results that you find. It doesn't add anything on a population health or a hospital health level. So I would question the assumption that the point of care drug test is the gold standard. It's actually a better standard is self-report.
Yeah, and I think
for this context.
Yeah, to emphasize, I talked a lot about obviously the limitations of the biological testing, but the point is not that we don't care or that we don't want to know whether people are using substances. It's that there may be other, even better ways to find that out, which, as Dr. Terplan said, really asking the patient and relying on their report if it's done in a way that that they feel comfortable sharing has been shown to be just as effective in terms of eliciting their substance use history as just getting a drug screen. And then also without the kind of accompanying problems that you can have with false positive results, false negative results. And I think that really just the key, as far as the gold standard question, like any test that we have in medicine, is understanding what the test can and cannot tell us and being able to interpret the results in a way that is accurate clinically.
Yeah, I think that's spot on. I mean, especially when you think about like what you're saying, like how do we teach, let's say medical students how to use, about a test in general? We say only order a test if it's going to change the clinical practice, and understand the test so you can interpret, the results of it. That's like basic medical, like student literacy. And I would say most urine drug tests, in particular those that are ordered on labor and delivery, fail by that, medical student standard of what a test is and when to order it. We're not ordering it for a clinical indication. It's not a drug test, it's a moral test, or it's a parenting test. We misinterpret the results as being indicative of somebody having an addiction. It's a presumptive test that measures metabolites of use. It doesn't say anything about whether or not somebody has a use disorder in and of itself. That's a diagnosis, and addiction is the symptoms of addiction are behaviors. Craving, compulsive use, continued use despite adverse consequences. There's nothing in a urine drug test result that is indicative of behaviors per se, even if it did measure things better than it does, and it doesn't measure things very well. So I think that always bothers me, that we've the sort of basic premise of laboratory utilization of laboratory testing in clinical care has been to a large extent sort of like abandoned or forgotten or overridden, in the context of drug testing in pregnancy.
Yeah, and I can, to that end, I can understand why we do them and why, as primarily what I do is clinical work, why people feel that when they order them that they're doing the right thing, because they're wanting to, make sure that they can give information about the baby and they can, know information about the mother. But I think also sometimes it can be a way to kind of get out of having an uncomfortable conversation with the patient too. Because if you can just say, well, we order drug screens on everyone, and then find that information out, and then it goes to the pediatricians or to the social services team or whoever, then really the OB ordering provider oftentimes never really has to, if they don't want to, address it with the patient, although obviously we should. But it can be an interesting way of a little bit of avoidance of having to have that conversation too.
Yeah, and I I understand, the sort of the instinct to avoid confrontation or difficult topics or whatever. But if you now have a urine drug test with a positive result, not having had an initial conversation, this next conversation is much more difficult to have. You
Yes,
have not set yourself up for success. You've not set the patient up for success. And I think the onus is on us as providers to create environments that are welcoming and to ensure, as much as possible that, people feel, comfortable with disclosure, in particular disclosure of things that are sensitive, that have a criminal justice or a child welfare sort of interface to them. And I think we owe it to the universe, but we owe it to our patients to have those conversations as well. And just like I think generally speaking, people who work in the reproductive health space are pretty good at talking about the sensitive topic of sex, with with patients and sexuality and stuff like that. And on the whole, people who work in the drug treatment world are pretty good at talking about, drugs and drug use and some of the, activities related to that with patients. Like, so all those are examples of how we can learn and how we do actually engage in sensitive conversations around things and other topics. It reflects our own discomfort, as you're saying, more than anything else.
Mm-hmm. Yeah, and I think it's really important as we are training our younger providers and physicians to teach them about how to have those conversations. And, I see with our residents, it really is a learning process about how do I bring this up with a patient, especially maybe if it's someone you've never met who's coming into labor and delivery, and how do you initiate that conversation and do it in a way, again, that is going to create some trust in a situation that's pretty transient. A lot of times in terms of the episode of care, you may just meet them, depending on your setting, meet them when they come in to have their baby, and then may never see them again. And so I think it's really important that we figure out better ways to train our younger providers about how to do that.
Yeah, and I agree that is difficult, and that really, like I never, I don't, I'll just say it this way. When I see a healthcare provider, I never fully disclose information to them. Like I never do. Nor would I, if I don't do that myself, why would I expect, one of my patients to be completely forthcoming, with me, especially initially. But over time, it's like the chronicity of especially outpatient care, you can establish that relationship. Now, when you have just these episodic visits, especially around like the birthing, hospitalization, et cetera, I would say the bar is even higher to stand up and to treat people with dignity and respect, because you might not see the effect of your empathy and your positive behavior and you explain the consent, or that you explain the concept of consent, or why you're doing. You might not ever see that, but that doesn't mean that it didn't have a positive change. When I ran an outpatient addiction treatment clinic, I would oftentimes ask new patients, like, when did you decide to come to clinic? And oftentimes it would be some of these single episode moments. The last time that I was in the emergency department, somebody sat me down and talked to me like a human and told me about this program. And so we don't see those seeds that we sow. Like one reason is you treat people with dignity and respect because that's the right thing to do by the universe. But the second reason is because it actually does help. You might not see it, and just because you don't see it doesn't mean it wasn't effective. Or doesn't mean you should shirk, behaving in that manner, in that moment.
Yeah, absolutely.
And again, it's the drug test. Everyone gets all bent. Just why not focus on screening and assessments, having a conversation with somebody? And it doesn't even have to be a directed one. Do you have any questions or concerns about smoking, drinking, or other drugs?
Yeah, absolutely.
I'm loving this discussion. It really is keying in on several of the other questions that have been sent to us. I'm going to ask two of these together because I think it really fits in with what you were talking about, the screening and how to talk to patients. And you were talking about bringing this up to, teaching student physicians as they're going through, but then also about the physician that's been in practice for a long time. So the two questions are, do you have suggestions to get staff and physician buy-in for non-judgmental care and screening and referring to treatment? The second question is, it seems that pre-hospitalization discussion with mom on what to expect is very important. How might these discussions be handled?
Yeah, so the first question, how to get buy-in from other people. I think one of the things that comes up so often is making sure to equip people. So if you're saying, trying to talk about how important it is to ask these questions and to initiate these conversations with patients, the next thing is to know what to do with it whenever they come back and say, yeah, I do have, an issue with X substance. And so I think that can be, certainly a barrier for a lot of providers in asking these questions. And so I think that making sure, at a local level, at a state level, like we're doing here in Oklahoma, and I know in many other states, just trying to make sure that all these resources are available and they're easy to access, both for providers in referring patients and then also for the patients themselves. But honestly, for me, from what I see, I think that's really the biggest barrier, is just what to do with the information once you get it. I think the second barrier also is probably time, and people think that it's going to, if they ask these questions, they're going to go down this whole, pathway, and it's going to take up the rest of their morning clinic time or whatever. And so I think, again, equipping people with a, simple way to refer people once they find a substance use issue, and, making it so that it doesn't have to be, this big production that's going to derail, the other patients that this provider is trying to see in clinic, which is also important. But I think that kind of facilitating the resources is one of the first steps for that, and making sure that the providers know about that, and that they know that, yeah, we recognize this is an issue, and here's what you can do next.
Without a doubt, resources are key, and people should never feel isolated. And in operating, providing care, like, beyond the bounds of comfort. And that's where I think things like that, the UCSF substance use warm line is a great resource, because you can literally call somebody who will, pick up the phone and provide, just another set of ears and eyes and feedback. So yeah, local resources, and it's and using them, and the ones that are easily utilized into clinical practice. So knowing who to call. In addition, I think in terms of the sort of like non-judgmental, kind of behavior change of providers and staff. I think one way is through modeling. Modeling appropriate or empathetic behavior. The second is, the term upstanding, which really comes from, really physicians and, white physicians in positions of power even, but anybody, sort of saying something, and, when you witness like acts of discrimination. It's really primarily been described around, gender-based discrimination and racial discrimination. But the same is true. The same principle is true when you see, somebody, saying something derogatory about treatment or about addiction or something like that, not letting it slide, right? Ignoring it actually gives it value and gives it meaning, and speaking up to it, upstanding. And I can send it. There's a nice New England Journal article about kind of like how to do it. Relates to race, but I think applies directly in the context of addiction. And another thing is, ideally, I think you guys are doing this to some extent, but involving people with lived experience, and supporting them in the programming of public health in this space. And that's super important. But the idea of, centering the clinical care provided on the most marginalized, or perhaps in this case on pregnant people who use drugs. One thing I think all providers can do is take a look at your office. Look at what are the pictures on the walls? Like, does this appear welcoming or not welcoming to a pregnant person who's, uses drugs and might be accessing services for the first time? Like, what does the entryway look like? How are they greeted at the front desk? All of that is is super important. I think it's actually like a good thought exercise. Like, imagine, the clinic through the eyes of, of a pregnant person, using drugs.
Yeah.
Go ahead.
No, I didn't want to interrupt if you had something further.
Go on. Yeah.
Kind of to that end, and to the second question that Barbara mentioned about discussing with patients prenatally and kind of preparing them for what they're going to experience with their birth hospitalization. So that's really important on several levels. One of the first is integrating their experience as much as you can from your clinic to the hospital. And I know that in some settings it's harder or easier to do that. It's pretty, as easy as it could be in my setting, because we take care of all of our patients and then we deliver them here at this hospital. And so, we have people that come in that drop in, for deliveries, but most of the people that we deliver are people that we've taken care of. And so, seemingly easy to kind of integrate those experiences, but actually, in going into this and kind of the process that we've gone through here is figuring out all the people that are going to talk to these patients when they're both in your clinic and when they're in the hospital, and how you can make that, an experience that is positive and welcoming and affirming across all of those settings. Because, labor and delivery nurses and staff aren't in your clinic. They've never seen these people before. And, they just have a very different perspective than people that have been seeing these patients in clinic every, couple of weeks for their whole pregnancy. So we've really, been working on just figuring out how we can, model those behaviors, those language, considerations that Dr. Terplan pointed out so nicely in his talk, and just how we can start to change the culture around how these people are viewed when they come into the hospital too. I think that that's really important. And then I'm always really interested to ask patients, what was their experience like? What was this experience like compared to your last pregnancy and birth? And of course, it's always really nice when you hear, oh yeah, it was great, and I wish that I'd, had this experience in my other ones, but you don't always hear that. And sometimes you hear, things that we can do better with. So I think talking to the patients and figuring out what are the things that you don't realize that are causing them to have negative experiences in your care.
Yeah, I like that distinction between things we can control and things we can't control. And I think that's really important to kind of lay out during prenatal care. And I oftentimes use that language, like there's things I can control, there are things, I can't control, especially since I don't cover labor and delivery anymore. I can visit people there, but I don't actually deliver babies anymore. But I can control, we can control, the content, the documentation, I can't control whether or not you will be drug tested on labor and delivery. And I can't control what happens to that information, but I take responsibility for your care that extends through the course of the hospitalization and beyond. And if you get reported to child welfare, I will write letters on your, attesting to your, stable and recovery, blah, blah, blah. I will, go and even testify if it comes to that, in sort of acknowledging, responsibility and being specific about what it might look like. I think, around that, those are things I can control. I can write a letter to, to the judge about your treatment course. But I can't control whether or not the notification will be sent from the birthing hospitalization.
Yeah, and one thing that I've found to be really interesting, Dr. Terplan, I'm interested in your experience with this, but realizing how many complexities there are once the baby is born, and once the child services does become involved, and how it may kind of emphasizing with patients, even if you haven't used any other substance, other than your methadone or whatever throughout the pregnancy, there's a lot going on at their home that obviously I have no idea about. So I don't know, there could be safety issues that I'm not aware of. And these are just things that I think to myself, but I've found a need to kind of emphasize with the patients too, that it's not necessarily only about your substance use, that, there are other things that get taken into account in terms of the what happens after birth with the baby. And You know, I don't like that because I like to think that I know like what's going on with the patient, but it's just interesting. I've had some experiences where, you know, there are things that we have no idea about necessarily, just because they haven't told us. And hopefully, you know, they'll be forthcoming, but it just may not be something that has come up or that they feel comfortable bringing up as far as what's going on in the home environment. And that those things can come into play too. And even though they've been doing great and they've been really stable in their recovery, there could be other factors that come to play.
Yeah, I mean, I think somewhere this focus on drugs is like a diversion almost. It's you know, I would say most people you know, need or would benefit from like a whole range of resources following birth, not just people who use drugs, not just people, you know, with SUD, but a whole, you know, whole range of services that, you know, should be individualized. Yet there was a period of time in the state of Maryland where they had a part of CAPTA. This was like 2010 to like 2015 or so. They had an alternative reporting mechanism. So not a child welfare. If it was substance exposed newborn, it went through this alternative mechanism. And I was initially skeptical of this, but it turned out to be this really wonderful resource because they were able, through that mechanism, some other state work, to get resources they hadn't had before. You know, for Section 8 housing vouchers, for more like food stamps, transportation. They had all these resources, which were actually, you know, like important resources in general, not just for people who use drugs. With the recent CAPTA reauthorization, that pathway kind of collapsed, and those resources in that way a little bit went away, which was like unfortunate. So I think it's like, I would like it if we could uncouple somewhere like substance use from like what families need to raise their children, you know, as well as possible in environments that are safe. And it's hard, you know, it's hard to see how to do that without like sort of more like radically rethinking. But I would agree that lots of people need support, and we should find ways to bring it to them. One thing that I don't know the details in Oklahoma, but something I've shockingly only recently learned a little bit about is like early Head Start. Which, you know, I think only 8% of people who would be early Head Start eligible actually receive any services, to a large extent because people don't know about it, and two, like the services don't always exist very well. But there's there are lots of programs, especially in the postpartum period, that can be beneficial for some people that we don't, that child welfare isn't necessarily, it should not be seen as the only door to, and may not even be the best way to get people connected to those kinds of services.
Mm-hmm. Yeah. And where Barbara just mentioned in the chat that we are working on creating, it sounds like something similar to what you mentioned as far as like a dual pathway for reporting versus notification with substance exposed newborns, which is exciting. So it'll be interesting to see how that plays out. But as far as a little bit more in terms of things to kind of prepare people for and what you can talk about, and things that I found helpful at least is, you know, we all know if someone's on chronic opioids in pregnancy, talking to them about neonatal abstinence syndrome is important. And I have found that really giving as much detailed information as we can about how long the baby will be there, getting observed, and that varies obviously depending on the institution, but we've worked really hard with our pediatrics group to kind of get that sort of standardized in terms of how long they keep these babies for, and you know, babies of moms that have been on particularly like methadone and buprenorphine. So then we can kind of be saying the same thing to the patient. This is usually stay for 5 days. You know, we'll discharge you, but then you can stay in the room with the baby. And that seems to have really helped a lot in terms of just preparing them for what like the actual physical few days in the hospital following birth will be like. And then we've actually, and I know this isn't an option for everyone, but you know, some version of this potentially is having our patients who are on opioids meet with our pediatricians to do a prenatal consult beforehand, before they deliver in the 3rd trimester, so that they can, again, like get some of those questions answered about what's going to happen with their baby, what they should be watching for, things that they can do to try to alleviate some mild withdrawal symptoms if they have them. And that's been actually really even more powerful than I thought for our patients, which has been really cool, just because I know that obviously their main concern is, are they going to take my baby away because I have a history of drug use? And so I think just giving as many of those details as you can really helps to empower them and give them a sense of, at least a sense of what's going to happen in some way when they may not know everything that's going to happen.
Yeah, that's huge. And I really, yeah, and yeah, I nailed it. So like, it's kind of like, what to expect, and tools of sort of self-empowering and supporting. The only thing I'd add to that is that oftentimes, and this is more around, I think, when I'm thinking about like breastfeeding recommendations, like oftentimes hospitals are inconsistent across different spaces, different messaging in the NICU versus the general care nursery, and can be different from different providers. So consistency, like within the system is also like incredibly important, and needing, sometimes you need to do like a crosswalk. How is this being talked? How does the anesthesiologist talk about, let's say, like, another thing to talk about is like postpartum or discharge opioid prescribing, that people might hear multiple contradictory and quite different messaging on lots of these topics within a single hospitalization. And that doesn't, yeah. That undermines all of that strong work you did to some extent, like during prenatal care.
It does. And I mean, I'm sure you've had this too, but I can't tell you how many times I've had patients say like, oh, well, like my nurse told me that I shouldn't breastfeed, but you've been telling me I should, like, what's up with that? Or, the lactation consultant said something different. And so it's crazy how many different people someone comes into contact with just during that birth hospitalization.
Mm-hmm. Yeah, clear, consistent messaging, across the birth hospitalization. Totally.
And I think that is one of the advantages of initiatives like this, and taking a hospital at a time on, is making sure that we don't have too much mixed messaging. Another question that has come up is that many OB providers are uncomfortable diagnosing SUD. So if they are concerned, but not sure how could they refer if they're not really comfortable making this?
Well, I mean, diagnosis is important, and it's certainly important from a medical documentation prior to initiation of medications for the treatment of opioid use disorder. But more important somewhere is treatment. And second, the diagnosis is really pretty easy. It's like there's like 11 questions in the DSM. And they're like yes, no, and you add up the numbers. I mean, it has been operationalized to a very easy kind of level. But and I encourage people to read like through the diagnostic criteria, and you don't have to go through all 11, because if the first 3 or 4 are positive, then you have the diagnosis. You don't need to keep documenting more necessarily. But to me, sometimes I ask people like, do you think you have an addiction, and would you like treatment? Or are you aware of medications for, let's say, opioid use disorder, and are you interested in starting? And yes, I need to document a diagnosis to initiate medication, but like the important part is the initiation of treatment. So that can be done. I mean, this is where the warm line can be helpful for helping support people in initiating medication. There's been a slight change to the buprenorphine waiver process, There's certainly like people around, and then having resources. So the other thing, and you mentioned this, Dr. Pierce, but I would encourage people who've never been to an OTP or an addiction, medicine program, don't even know where like treatment is necessary. If there's a facility in your region or you're locally, like call up the phone and say, we're prenatal care providers. Like, can we have a little Zoom meeting? Can we go over there, or you come here and tell us what to do? Because there's nothing better than having like a real human relationship between clinical spaces that really can ensure, continuity of care like way better. And it's a, like addiction people love talking about like what treatment is to other people, and other people, everyone's really kind of fascinated with pregnancy and prenatal care. So there should be like a resonance. So I would encourage you all to like reach out to drug treatment programs that are local, and arrange a visit or virtual visit.
Yeah, and I would echo that about the diagnostic criteria. So I'm not a psychiatrist, obviously, or board certified in addiction medicine like Dr. Terplan is, but as an OBGYN, it is actually like super simple to just read through the criteria, and you just have to have a certain number and then you have the diagnosis. It's really not anything more like complicated than that. And it's something that you can pretty easily find online. So I think I say that to like reassure people and to let people know that it's actually not as hard as maybe it might seem to make the diagnosis. But if ever you don't feel comfortable making it, I think the biggest thing is just not making that uncertainty or that discomfort, not letting that be a barrier to the patient getting treatment if she needs it. And so most of the time, probably if you're thinking, I think this person might have a substance use disorder, you're probably right. They probably do. And I think that, like Dr. Terplan said, it's also really easy to just ask the patient, do you think you have an issue with this? And would you like some information about treatment? And then if she says yes, then, you have your answer, and you can go from there and use the resources that you have. But yeah, I understand that concern, because that's something that I have felt before. But really, I think you can use your intuition for a lot of it as well, even if you're not, looking at the diagnostic criteria, but also just, Googling the diagnostic criteria, or, finding them on the SAMHSA website or wherever is pretty simple to do.
I mean, it's really, I would say how we monitor or how we control medications for addiction treatment is incredibly unfortunate. And on the one hand, we say it's a disease, it should be treated as one. On the other hand, like you have to have a special like X number from DEA in order to prescribe buprenorphine. And you can't prescribe anyone methadone for the treatment of opioid use disorder. It can only be, dispensed from a federally licensed like opioid treatment program. So that's a cognitive disconnect. That's unfortunate and unfair to people with use disorder. But my vision would really be, I think everyone has their threshold of, I think most general, like people who provide prenatal care are comfortable prescribing at least one antihypertensive, at least one SSRI, and certainly know their limits and know when, like when would you refer to like, a cardiologist or even another primary care provider or a psychiatrist or somebody for that. So my vision would really be that like how we do that in practice would include medications, for opioid and alcohol use disorder. I see somebody, they're 6 weeks from their primary care visit, but they're running out of their like whatever 7 different beds, 4 of which I've never heard of before. I briefly look them up and prescribe a month's worth to get them to their, net or whatever amount to get them to the next visit. I feel like we could all do that with medications for addiction.
Yeah, it's so true. And I think that like for me also hits a larger point. Like, I think sometimes, we make like a big thing about treating women with substance use disorders in pregnancy, and that they need these special things and they need this special care and whatnot. But then sometimes that like has a negative effect of then making people feel like, well, like I can't do it. Then I need to like send them to somebody who specializes in this or whatever, which, may be the answer sometimes, but I think sometimes it can be actually like a negative, make it kind of feel inaccessible to providers to be able to like provide this care as well, and make it feel like there's something magical about it that they don't understand or that they, don't know.
Yeah, totally. And it's because like addiction treatment existed outside of medicine for most of the 20th century. And we're just sort of shoehorning it into, and yeah, exactly.
Our next question was, due to cost, our hospital's routine toxicology test is the basic 7 panel. So we're missing the barbiturates, the benzos, the buprenorphine, fentanyl, all of that. A provider can order a higher panel, but most just order UDS. And so do you have any suggestions for what should be the minimal panel for biological testing in pregnancy?
Yeah, well, it's great that this person knows this information and knows like what the panel tests for. I think some people may not even have gotten that far. So I think that's really good. And I think that this goes back to knowing what your tests can and cannot do, and then realizing when you need a confirmatory test. As far as like which specific things that you'd want to test for, I'm guessing that there's probably mostly just predefined panels that you can't necessarily like add or subtract from. Dr. Terplan, I don't know if you have any other like thoughts on that.
Yeah, I mean, I think it's a really good question because it kind of it makes the point, which needs to be deliberate, and with like we need to know why are we ordering the test and what are we going to do with the results. And that might lead to ordering fewer tests if you can't answer that question, or what they're suggesting, they're perhaps ordering more selective tests, rather than, testing, like the Chem 27, you're like, I'm really only concerned about, the glucose. Sometimes you can't do that. Sometimes you can't. This other consideration is really knowing your local population. For the longest time, like PCP is part of like a standard test. Right now, in a place where actually there's a decent amount of PCP use, but it's the first time in my 20-year career that I've ever seen people who use PCP. I never saw it in LA, in Chicago, in Baltimore, in Richmond, Maryland. I see it in DC. So like knowing what your local is, and adjusting, to that. So barbiturates, probably, I don't know. I would guess that, unlikely to ever be positive, but or a true positive. False positive, far more likely.
Yeah, and I mean, on that note, I think it's probably not a surprise to any of us that are in Oklahoma, but opiates and methamphetamines are the big things that we see here, in marijuana, in terms of substances. So, obviously those would be things that you'd want to make sure, if you're going to be sending the test for a specific reason, those would be, I think, the substances of interest. But yeah, you may not always have the option, I guess, depending on what your hospital lab is doing.
And then finally, there is a question for you, Dr. Pierce, that says, can you mention the family care plan that you began in the previous?
Yes. Yes. So we are starting, or have started, a really, what I think is a cool initiative that is going at the statewide level that we've started doing in our clinic, in the STAR clinic, which is called a family care plan. And so this is sort of a precursor to the plan of safe care, which is what is required, at least in Oklahoma. I don't know if this is in all states, but it's a required element for substance exposed neonates to have when they're going home from the hospital. And it's sort of just a plan for safety after discharge. And the family care plan is a prenatal precursor to that, meaning that has kind of all the same elements, but it's intended for the parents to be able to have that information going into their birth hospitalization, so that when they're talking to our social work team and they're having to fill this out, they've kind of already thought through a lot of these things, like who's going to be the child's pediatrician, are there any specialists that the child's going to need to see for medical care, who are people they can call if they need somebody to watch their child at the last minute, what are housing, employment, transportation, what kind of resources do they have, and what else do they have to supplement those if they need them. And then again, with the idea that it's not just another piece of paper that they have to fill out or another hoop to jump through for providers, but this is something that the patient owns, that the parents own, to just help them get ready for their child to be here. And then also to just help them to feel more confident when they're going into their delivery hospitalization, that they've got a plan and that they can sort of articulate it whenever the social services teams get involved. So we started doing that in our clinic, and really, I think, having some positive reactions from our patients. I was really wanting to make sure that this didn't seem like a punitive thing, or it didn't seem it didn't have a negative connotation to it, but that it was seen more as a tool for families. And again, as something that they own. It's not something that I have to do or that I have to document anywhere, but it's just something that can help them if they choose to.
That is awesome. And I think I can share this now because it's out of committee. So CAPTA is being being reauthorized probably in this session. And in the draft language, the plan of safe care language has been removed from the new from the draft forthcoming, and they're using that the family care plan is the language that's being used in the in the federal statute. And yeah, it's awesome. It's more inclusive. You can sort of look at CAPTA, and it wasn't until like 2010 that it was recognized that infants came from the bodies of mothers, so that mother came with the language for the first time, and now it's the first time that family enters in there, and so it's actually a movement in the right direction in terms of language of legislation, but really representing precisely what you are doing in that clinic in terms of sort of comprehensive, and also demonstrating how this is it's like a urine drug test somewhere, and that it's a tool. Like the care plan is a tool. It's neither good nor bad. It could be wielded for good, or it can be wielded for evil. You can use it well, you can use it poorly. But in and of itself, it actually doesn't have value. We give it value. And you've given the plan of safe care like this extra value that is ahead of what's happening in the Senate right now. So kudos to you.